Investigating a systemic hematologic disease at its source begins at the posterior superior iliac crest. This site provides a large marrow space accessible for sampling while remaining safely distanced from major internal organs. The internal marrow cavity is a highly organized microanatomy. It consists of a matrix of bony trabeculae for scaffolding, with fat spaces and vascular sinusoids, interlocking with active islands of hematopoiesis, the clusters of cells manufacturing the body's blood supply. This environment presents a specific clinical challenge. We must diagnose diffuse malignancies like leukemia, lymphoma, or myelofibrosis by analyzing a tissue sample measuring only a few cubic millimeters. To capture a complete diagnostic picture, we extract this tissue in two physical states. The first is the liquid aspirate. Drawing out the fluid allows for high-resolution evaluation of individual cell cytology, including differential counts and blast percentages. The second half is the solid trephine biopsy. By removing an intact cylindrical core of bone and marrow, we preserve the structural architecture, the spatial distribution of cells, and the marrow's overall cellularity. The International Council for Standardization in Hematology specifies that the aspirin and the trephine are strictly complementary. They provide different data streams and are never considered competing tests. Relying on only one sample type limits the diagnostic view. Extracting fluid without preserving structure or viewing structure without isolating individual cells leads to incomplete or inaccurate interpretations of the marrow space. Liquid aspirate is obtained via negative pressure. Once the needle reaches the marrow cavity, a syringe creates a localized vacuum that pulls the fluid out of the trabecular spaces. The first pull must be a small volume, typically 1 to 2 milliliters. This ensures the highest concentration of native marrow particles, which are required for an accurate morphological analysis. If the operator pulls a larger volume immediately, the expanded vacuum ruptures the surrounding sinusoids. This floods the syringe with peripheral blood, diluting the native marrow in a technical failure known as hemodilution. Hemodilution causes false negative results in minimal residual disease flow cytometry testing. When a sample is diluted by normal peripheral blood, it obscures the actual malignant cell count, potentially leading to the report of a negative status when the disease is still active. The opposite physical failure is the dry tap, where the needle is positioned correctly and negative pressure is applied, but no liquid is obtained. A dry tap does not indicate an empty or aplastic marrow cavity. It is a failure of fluid flow, not necessarily a lack of cells. We evaluate a dry tap using the master differential FHMMO, fibrosis, hairy cell leukemia, metastatic carcinoma, megakaryoblast leukemia, and osteosclerosis. These conditions alter the physical state of the tissue. They pack the marrow cavity so densely or harden the stroma so thoroughly that liquid cannot move through the needle. When an aspirate fails, we rely on the trephine core. By rolling the fresh biopsy core directly onto glass slides, we create touch imprints that salvage the cytological detail from cells on the tissue surface. A technical extraction failure is frequently the first indicator of significant underlying pathology. With a high-quality aspirate, we focus on the microscopic level of the smeared fluid. This chart shows the myeloid-to-erythroid ratio. We calculate this by comparing granulitic cells to nucleated erythroid precursors, with a normal physiological baseline of 2 to 1 up to 4 to 1. A high M/E ratio does not always mean myeloid expansion. In cases of pure red cell aplasia, the erythroid compartment shrinks. This causes the ratio to spike even if the myeloid cell count is entirely normal. The aspirate is also used to assess megakaryocytes. These large polyploid cells normally feature multiple nuclear lobes and are found near the vascular sinusoids. We contrast normal forms against the dysplastic micromegakaryocytes found in myelodysplastic syndromes. These small, abnormally lobated cells are hallmark evidence of a clonal disorder. To evaluate iron storage, we use Pearl's Prussian blue stain. This identifies macrophage storage iron and cytorotic granules in developing red cell precursors. This is a ring cytoroblast. In these cells, iron accumulates abnormally within the mitochondria, forming a dense ring around at least 1/3 of the nucleus. Ring cytoroblasts are a morphologic finding with a broad differential, including copper deficiency, alcohol use, and certain medications. They are not specific for MDS and must be interpreted alongside genetic markers like the SF3B1 mutation. While the aspirate provides cellular resolution, it lacks spatial context. To see the distribution of disease within the bone, we must examine the solid core. An adequate trephine core should measure at least 1.5 to 1.6 centimeters. This length is required to include enough intertrabecular space for a representative assessment. Short cores increase the risk of sampling errors. A biopsy measuring only 4 millimeters can easily miss patchy focal diseases, such as metastatic carcinoma or focal lymphoma, that are present elsewhere in the marrow. We assess overall marrow cellularity on the trephine. Total hematopoietic tissue naturally declines with age, as it is replaced by fat, following a general guideline of 100 minus the patient's age. The trephine also allows us to grade marrow fibrosis on a scale from MF0 to MF3. This grading is based on the density and intersections of the reticulin fiber network. We distinguish between reticulin, type 3 collagen, which is potentially reversible, and true collagen fibrosis. The latter indicates advanced permanent stromal alteration and is identified using a trichrome stain. To map the exact distribution of precursors within the solid tissue, we use CD34 immunohistochemistry. This highlights the percentage and location of hematopoietic blasts. In healthy marrow, precursors follow a specific distribution. The abnormal localization of immature precursors, where blasts form clusters away from bone trabeculae and vascular areas, is a key indicator of MDS or AML. Because the trephine is encased in bone, it must be decalcified for processing. If a laboratory uses harsh acid methods, it can destroy the DNA and antigens needed for molecular studies and immunohistochemistry. The trephine biopsy provides the architectural blueprint, revealing the spatial distribution of the disease that the liquid aspirate cannot visualize. Integrated diagnostics are required to resolve difficult differentials, such as the profoundly hypocellular marrow, where fat replaces hematopoietic cells. In severe aplastic anemia, the trephine shows a marked reduction in cellularity, often below 25%, along with an absence of megakaryocytes and a lack of malignant infiltrates. This must be distinguished from hypocellular MDS. Accurate diagnosis depends on finding evidence of dysplasia or clonal genetic abnormalities, rather than relying on the low cell count alone. In myeloproliferative neoplasms, we contrast essential thrombocythemia, which features large hyperlobulated megakaryocytes, against prefibrotic primary myelofibrosis, which shows dense clusters of megakaryocytes with abnormal bulbous nuclei. This is a Gaucher cell, caused by a GBA1 deficiency. As glucosylceramide accumulates, the macrophage's cytoplasm develops a fibrillary, crumpled tissue paper appearance. This can be mimicked by the pseudo-Gaucher cell, which appears in high turnover states like CML. Because of this morphological similarity, visual findings must be confirmed by enzyme assays or molecular testing. We see similar pitfalls with hemophagocytosis, where macrophages engulf red blood cells and leukocytes. Visualizing hemophagocytosis on a marrow slide is not a diagnosis of hemophagocytic lymphohistiocytosis, or HLH. Hemophagocytosis is a nonspecific reaction to sepsis, autoimmune disease, or malignancy. Diagnosing HLH requires meeting specific clinical criteria, including elevated ferritin and soluble IL-2 receptor levels. In isolation, morphological patterns can be profoundly misleading. Accurate diagnosis requires that these visual findings be validated by clinical and molecular data. Modern hematopathology relies on the integrated marrow report, where physical morphology, architectural data, and digital sequences are aligned. Morphology and architecture establish the physical presence of the disease, while ancillary tests like flow cytometry and molecular PCR provide the specific genetic and immunophenotypic markers. Because flow cytometry and cytogenetics require viable, non-fixed cells, sample allocation must be planned before the procedure begins to ensure no diagnostic material is lost. If results are negative, we must account for sampling limitations. A negative report means the disease was not detected in that specific specimen. It does not exclude the possibility of focal disease elsewhere. No single cell count, architectural pattern, or ratio can stand alone as a final diagnosis. Final diagnosis relies on the synthesis of blood counts, aspirate cytology, trephine architecture, and ancillary molecular studies. A complete marrow assessment is only possible when all data streams are evaluated together.